lot of you still out back, but you're here for their remarks and not mine, so we'll get started. First and foremost, welcome to the 5th installment of the National Healthcare Forum Series. This forum started 2 years ago to champion the student voice on healthcare. I know there's a lot of students here and a lot more coming in. We got about 50 deep apparently. So eat a hearty meal and enjoy a hearty discussion of healthcare. This is all about you guys and learning about this system. You will not learn about it first or second year, and I can tell you will not learn about it third year. You have to go out of your way to do this, so I commend you for being here. We also want to emphasize that all perspectives are welcome here. The point of these forums is to discuss the facts. You are smart. You can take away from the facts what you wish. That's why this is sponsored by so many groups. We have no agenda here except to present you the facts and let you decide on your own. Again, we have a history of some distinguished panelists. I think this may be our best panel yet. As you can see in their resumes, they are very distinguished, and we're very excited to have them. First and foremost, I would like to thank the student groups who made this possible. This is Jefferson AMA, Medical Student Section, AMSA, the AOA Honor Society, Functional, the HAH, Internal Medicine Honor Society, the IHI, which is Institute for Healthcare Improvement chapter here on campus, JeffSAPHE, which is Public Health and the Public Health Society. I'd like to single out especially HAH and PHS as they were financial sponsors, making your meal from banana leaf possible, which is obviously delightful. I'd also like to thank the men of AKK. They were instrumental in getting the food here, which I know is the most important part of these events, and were critical to shaping this PowerPoint. So thank you, gentlemen, especially Andrew Miller up front. He'll make some comments, and Greg Snyder, who you met when you came in. He was instrumental as well in organizing and advertising this. We'd also like to thank our food sponsors, Jake's Sandwich Board, Milano's Pizza and Grill, Mumbai Bistro, and Top Tomato Pizza Kitchen. If you like what you're eating, we highly encourage you to frequent those locations and say the NHCF sent you. So looking at our panelists, you have their bios in front of you. As you can see, they are very distinguished, so I will keep my remarks short. On the far side, we have Dr. Barbara Connors. She's the Chief Medical Officer for Medicare and Medicaid Services, Region 3, which encompasses Delaware, Maryland, Pennsylvania, Virginia, West Virginia, and the District of Columbia. We have Mr. Neil Lubarsky, He's the Chief Financial Officer here at Jefferson Hospital. And Dr. Michael Rosko, he's a Professor of Healthcare Management at Widener. Again, I will refer you to their bios for more, as they have very impressive backgrounds. So let's get to the topic at hand, the cost of care, and I'm going to present you a flurry of numbers, and please forgive me for speaking quickly, but again, I want to get to the panelists. So $2.7 trillion, that's a lot of zeros and a lot of money. What does that mean in America? 2.7 trillion is annual healthcare expenditures. Okay, and what does that mean in France, the 5th largest economy in the world? 2.7 trillion means total economic expenditures. So if you compare those, we in the U.S. are spending in healthcare dollars the 5th amount out of all industrialized nations. And you may be wondering how this does affect federal spending. Obviously, in an election year, this is a hot topic. Medicare and Medicaid account for 23% of 2011 outlays. And you may say, oh, well, that's not too big of a problem. But in the next 9 years, the healthcare expenditures are predicted to nearly double. And you'll hear figures tossed around again this election year about savings for different proposals. You'll hear millions of dollars saved here, billions of dollars saved here. We're looking at spending $36 trillion in the next decade. So please keep this all in perspective when you hear the numbers on the TV or discuss it with your friends, family, if that comes up at the dinner table. So you may wonder, how do we compare to other industrialized nations? As you can see, we are a bit of an outlier in per capita spending at nearly $7,500 per capita, with the range of industrialized nations going as little as $2,700 in Japan to a high of $5,000 per capita in Norway. Of interest, from a public expenditure standpoint, we're pretty much even with other industrialized nations at 7.4%. But the issue in America is that we have private expenditures that are more than that on top. So as you can see in other industrialized nations, public expenditure accounts for the majority of the disbursement. Here, private expenditure does, but we also have a similar amount of public expenditure. And you may wonder, were we ever like the other industrialized nations from a per capita standpoint? Sure enough, we are. If you look back to the 1970s, we were right in the thick of it. As you can see, in the 1980s, we started to distinguished ourselves from a healthcare spending standpoint, and we took off again in 1990 and then got apparently a third win in 2000 and took off yet again. Now looking at the U.S. specifically, if we look at where we started in the 1960s, we were spending about 5% of the GDP, but by 2000 that nearly tripled to almost 14%, and today we're spending nearly 18% of our GDP on healthcare expenditures. Now you may say the American economy can produce a salary that keeps up, but as you can see here from 1999 until 2011, worker compensation tracked approximately with inflation, whereas healthcare insurance premiums and workers' contributions to premiums grew at a far greater clip, going up 160 to 168% in those 12 years. Now, all healthcare spending is not equal. Now, per capita we spend $7,500, but the people in this room do not spend the same as many other people utilizing healthcare. As you'll see, the top 20% of healthcare providers or healthcare utilizers account for 80% of all healthcare spending. The bottom 50%, which is most of the people in this room, only utilize 3% of total spending. Now, where's that money going, you say? Well, frankly, it's going to you and me, or at least when we're future physicians or healthcare professionals. As you can see, more than 50% of healthcare expenditures are accounted for in hospital care, physician and clinical services, whereas a far smaller percentage is accounted for prescription drugs, other hospital spending, nursing care facilities, and the such. Now, I know a lot of you are first and second year students, and you may be wondering, what does this mean for me as a third year? I'm sure you're hoping that I'll have some advice for step one. I don't, but what I can prepare you for is what you will see on the floors starting in July. So the first thing you will hear is about these isolation gowns, and you will be told that they're $10 an isolation gown, you'll hear that they're $4 an isolation gown, and you'll hear everything in between. If you actually look that up, you'll find out that they're 60 cents per, and it's really not that bad. But you'll hear other rumors. You'll be in a surgery, and a surgeon will pull this thing out. It's called a ligature. And they will say that this isn't the right ligature. They will throw it out without using it, and someone will joke, well, there goes $2,000. Turns out they're a little off. It's $925, but you will see it. You also hear that every minute in the operating room costs $100. And from my understanding and talking with some surgeons and people in the industry, that's about right. So get used to some crazy numbers. You'll see IV bags, you'll see TPN, you'll hear residents arguing over how much it costs. One resident will say $50 a day, another resident will say, gosh, I think it's $5,000 a day. And frankly, if you poll people in the hospital, they won't know. The answer is I think Medicare reimburses something like $1,400 a week. If you have private insurance, you will be billed something between $3,000 and $6,000 a week. So in short, both your residents are wrong, but be sure to tell them they're right so you get a good grade. You will also see more CTs ordered and read than you ever thought possible. You will see more chest x-rays than you can care to imagine. You also see daily labs over and over and over again, and you will wonder how much do these cost? Are these important? What is the point? And as a third year, you will be very used to finding hospital charts and hospital records. You will become very familiar with that. If you can see it, that's a Jeff chart. I made it small for HIPAA reasons. But I believe Jeff chart was created in the late 80s. You will learn to love it for some aspects and learn to hate it for other aspects. You also find out that the hospital runs on Internet Explorer 6. That first came out in August 27, 2001. If you're technologically savvy, though, you'll realize that the reason they haven't upgraded is that this is the only way to interact with the image server. So for those of you who are a little bit on the technologically advanced side, you will download Firefox, but you won't set it as a primary browser because your attendings and residents will be very mad at you when they can't access that CT that they ordered and then the CT they ordered again the next day. You also get very used to fax machines and wondering, gosh, if it takes me an hour or two to find outside records on the 1 to 2 patients I have, who's finding these outside records for the other 14 patients on the census? What you will learn real quickly is no one's really getting those outside records. There's poor communication. And communication even within the hospital, you get used to something called chart checking, which is where a consult was called in on your patient and you will go find out what they said. But this is I found this, I think it was telling. you will find out that if you are to tell your attending what the other attending said, you won't know what the other attending said because you can't read their handwriting. And you will take that chart to nursing stations and say, can you read this? And you'll make out maybe 50% of it. It'll take you 10, 15 minutes, and then your attending will end up calling the other attending and finding out something else entirely differently. So these are the realities on the ground. As a third year, you will learn to love it, I hope, and learn to think about what you can do to better the system. So looking at some analysis perspective, I'm sure you guys are well read on this topic, so we just want to touch on kind of two articles here, both of which came out in 2009, one of which was in the New York Times, looking at end-of-life care. It stated, I think it's from the either Dartmouth Atlas or Medicare rolls, that approximately a fourth of Medicare costs are spent the last year of Medicare patients' life. They also looked at the last 6 months of life at UCLA, which is consistently one of the highest expenditure hospitals, and the Mayo, which is consistently one of the lowest. UCLA in the last 6 months spent nearly double at $50,000 per patient than Mayo, with similar outcomes. The UCs were a little riled by this, so they got their own study looking at not only deceased patients, but those who lived, and found that in the elderly with CHF, obviously a much more focused group than the Dartmouth study, that health spending seemed to be correlated with sometimes better outcomes. So it is confusing, and I'm sure the panelists will talk about this more. The inspiration for this talk was Dr. Gwande's article, The Cost Conundrum, which looked at Medicare spending in Texas, specifically McAllen, Texas, which is the lowest household income in the nation, but the second most expensive healthcare market in the nation. They looked at the demographically similar El Paso and found that McAllen was spending almost double what they were spending in El Paso. Perhaps the biggest takeaway you can get from that article is this quote: "The most expensive piece of medical equipment, as the saying goes, is a doctor's pen." This article focused on physicians ordering more tests. You can see the quotes there for yourself. More tests, and physicians' own hospitals with their own skin in the game, where incentives were aligned for them to order more tests for their patients. He concluded with, I think, which is a very telling comment, whom do we want in charge of managing the full complexity of medical care? Because in much of the country, no one is in charge. And we're going to talk about a lot of terms and issues today, and I'll now ask Andy to come up to go through those in a very brief summary. Hopefully it's not too much of a whirlwind.
Do you want to?
Yeah.
Okay. So sorry, I'll do my best to speak loudly here. And I'm not going to take too much time. I just want to go over a couple of concepts and ideas that have been proposed for the containment of cost of care. So just bear with me here. Reimbursement schedules. So I'm sure a lot of you are familiar with a couple of these, and this is in no way an exhaustive list. But some of the more common ones you have your traditional fee-for-service, you have your capitation, where you have fixed payments per member per month, and then you have your prospective payment methods, which is basically the idea of Medicare here, where you have reimbursements that are predetermined for a particular case. In Medicare, that's the diagnosis-related group. And unfortunately, none of these reimbursement schedules are without criticism and flaw. And so the idea goes is there really a one-size-fits-all reimbursement schedule that really optimizes costs and quality of care? And this is a very interesting model. I pulled this from the Center for Healthcare Quality and Payment Reform. And essentially, it's sort of like a cost model mosaic. And you'll see here that essentially they're integrating all types of reimbursement schedules, be it fee-for-service, be it capitation, be it episode of care payment, and comprehensive care payment. And so the whole idea here is that you can implement a variety of reimbursement schedules depending on the type of care and medical service you're providing. So it's not one size fits all, but in fact here we're really tailoring reimbursements towards different types of medical care and services. And so your y-axis here, you have the total cost, the amount per episode. On the x-axis here, you have your variation of episodes per condition. And so fee-for-service, for example, might work very well for immunization, simple injuries. Your comprehensive care, which incorporates your primary care services to prevent things like COPD, congestive heart failure, those also play a role. So the whole idea here is depending on the chronicity, the severity, the cost of each care, all these reimbursement models may in fact play a part in optimizing cost of care as well as quality of care. And what's healthcare reform without at least talking about malpractice reform here? And that includes tort reform, caps on pain and suffering. Currently, there's the Health Act being proposed in Congress to address medical liabilities. There are healthcare courts, minimizing and restricting fees for. That's very nice. Minimizing and restricting fees for lawyers in courts. And then there's no-fault insurance, where regardless of who's at fault, you get compensated. And this idea has taken hold in places like Australia. And then there's craftier financial solutions like malpractice insurance, securitization, that have yet to take hold. But there's a variety of different proposals for malpractice reform, and that certainly will play a large part in the healthcare debate to come. Accountable care organizations, I think, get tossed around a lot, and I think, in light of the recent ACA passage, this has become a very important term in healthcare reform. And so, these are really an attempt to bundle patient care in order to improve care quality and cost. And so, by fostering coordinated care, the idea is that we can generate efficiency and less unnecessary spending. Now, unlike HMOs, these are clinician-run, and the beneficiary also has the opportunity to join ACO, and they retain the choice, which is different from the HMOs of the past. Now, there are clear benefits too. There have been demonstrable reduction in cost and quality of care improvement, but there are also concerns that remain right now, particularly the startup cost, the investment cost, increased hospital control over patient care, and the whole idea of the hungry horse guarding the granary is, if hospitals are really taking more control of these ACOs, is it really in the best interest from a business perspective to have these ACOs be controlled by hospitals? Again, certain criticisms, not all of them are with merit, but certainly a concern here. And then there's the skin in the game approach. This is your free market approach, your consumer-driven approach. These include ideas like health savings accounts, implementing and pushing for more catastrophic, high-deductible health insurance. Currently, right now, they're talking about ending employment-based health insurance. That was very popular during the 2008 presidential elections. Expanding insurance portability, beyond your employment so that you can take it with you where you go. And then, of course, there's another popular skin in the game, free market approach, which includes purchasing health insurance across state lines, sort of the idea of forcing state regulations and regulators to compete with each other. And then, of course, we also have, the single-payer system, which is another aspect here on the other side of the spectrum, and a slightly more radical approach, where we look at publicly financed healthcare, that still utilizes private delivery. It's just it basically takes the public finances, tax bases, to pay for it. And the whole idea here is by centralizing the public financing of it, we can reduce inefficiency, we can eliminate waste, we can eliminate administrative overhead costs. And the whole idea here is that hospitals would receive a global budget and operating expense for that year. And so I know we're running a little short on time here, so I'm going to hurry up through the last part. And this is just kind of a hodgepodge of ideas we threw in here, hopefully that we can expound upon in our discussions. But it's really the idea of preventative medicine, electronic health record, interoperability among different hospital groups. Alan mentioned the 30-year perspective. I've been to multiple different hospitals where nothing is continuous, and it's very frustrating, at least from a 30-year perspective. But that can go a long way, again, to generate savings, to make efficiency more widespread in the hospital system.
All right, so that was a whirlwind, and now we will continue with what I trust will be some very insightful comments. So we're going to get to the panelists' introductory remarks. We'd like to start with Dr. Connors.
Well, I would like to say that you both had it nailed. When I received your PowerPoint, I thought, okay, let me take out most of my talking points. And I will say that my main responsibility is to be out there talking to docs, and most attendings in practice 10, 20, 30, 40 years are not aware of what you just heard. So you're way ahead of your peers in that sense. Okay. I left one slide in. I want you to see we're pushing 18% of GDP at this current moment, but we're headed on a steep incline if we don't rein these costs in. I mean, this is Greece. And it's not entitlement, it's healthcare spending. So really everyone in this room has a fiduciary responsibility to this country, because you're going to practice, to rein these costs in. We all know that Medicare reimbursement rates vary considerably across the country. This is from the Dartmouth Atlas. And if you look at the areas where the highest reimbursement rates exist, these are hospital reimbursement rates, we're going to see the lowest quality of care. What drives the cost? It is the availability of the acute care services. So areas where we have more acute care available, we're spending more, but we're not seeing better outcomes. This is from an article, 2003 New England Journal, McGlynn. They looked at 30 quality indicators. And it is clear that in only 54.9% of the time when a patient sees a provider, they're getting the appropriate care. Yet, as a payer, Medicare, Medicaid, and all the private payers, we're paying 100% of the time. Now, this was almost a decade ago, and yet we know now still heart disease and strokes cause 1 of every 3 deaths. We have over 2 million heart attacks and strokes each year. And every 34 seconds in this country, someone has an MI, and every 3 minutes, someone dies from an MI. You see those that actually survive the MIs in the community. Treatment accounts for 1 in every $6, and heart disease and strokes is the greatest expression of disparate health care in this country. Yet, the status of the ABCs, now remember 2 slides ago I showed you McGlynn said 10 years ago only 54.9% of the time we're getting the right care, but patients in this country that should be on prophylactic aspirin, only 47% of the time they are, blood pressure control 46% of the time, cholesterol control 33% of the time, and smoking, those that get help when they're trying to quit, 23% of the time. These are the patients that you're caring for. We can't talk about controlling health care costs unless we talk about quality and safety, because embedded in these costs are billions of dollars of lost monies because of inadequate care or missed opportunity for care, and because of unsafe care. Not intentional. We use the word harm. We do not believe it is intentional, but there is harm. Healthcare-acquired infections, their bloodstream, urinary tract, pneumonia, surgical site infections. I spent 2 hours on a call today because of all of the infections we've seen over the last 5 years from providers using single vials for multiple patients. It's happening. 1.7 million HAIs in the hospital alone, unknown burden in other healthcare settings. Many of those settings that occurred in surgery centers, ESRD facilities, and in particular pain clinics. If we applied what we knew, we would reduce HAIs by 70%. It's all in prevention. Making the case for safety. On any given day, 1 in every 20 patients in American hospital is affected by a hospital-acquired infection. So you're walking around 1 in 20 patients. Among chronically ill adults, 22% report a serious error. 1 out of 7 Medicare beneficiaries is harmed, causing at least $4.4 billion. We really don't know. And medical harm is the 4th leading cause of death in this country. That's just death. not disability, not lost income as a result of medical harm. And we really need to do better. Now, if you look at health affairs, they'll say that those numbers are actually 10 times higher than what I just told you. So we really don't know. We're starting to look at those numbers. How do we know in the Medicare population? We know by claims data. So what do we get from claims data? The claims that we receive are, it is information extracted from the record, written by the physician or the provider, and the coder extracts it. Now, if you've never been down to billing, you should go down and talk to the coders. It's about a year course, post-high school. They are taking your information, submitting it to Medicare or the private payers, and the hospital gets paid and the provider gets paid. You probably would have your own biller. Hospitals are paid under Part A, DRGs, and we'll probably get into that in a little bit, because it's critical that you understand that if you are the surgeon in the OR and you're choosing a hip that's $30,000, the hospital isn't going to get paid what they're paying for that hip. They're going to get paid under a DRG. Now, the doc is incentivized by different payment mechanisms. The doc in the hospital is paid under Part B, and I'll get into that in a minute when we talk about ACOs. It's aligning incentives. What's CMS Survey and CERT doing? And this is near and dear to my heart because I just came off a year and a half of being the ARA for Survey and CERT, and I had Maine to Virginia, West Virginia. And we saw a lot of wrong site surgeries. We shut down ORs. We saw a lot of problems. Where, let me just tell you the one story. This was a hospital in Boston, probably well known to all of you. And the surgeon told us the reason why in 1.5 weeks there were 7 wrong site surgeries was because there was a cognitive misunderstanding between the fellow and the attending. Both had English as their primary language. The surgeon was not in the room, and somebody was miscounting the spine. But we were still paying. Then the patient would go back and have more surgery or have more disability, and we were still paying for it. So what have we done? We have incorporated requirements for survey. You hear about JACO coming in. JACO surveys based on what we require them to look at. We just had the training. JACO was there. So now there's 3 surveyor tools. Quality assurance, performance improvement. If you don't know anything about it, it is extremely important for docs to learn about root cause analysis. You will be required to do this not only on the floor in the hospital, but more importantly in your own practices. Why are you having problems? You have to do a root cause analysis. Discharge planning, and I'll get into that in a minute. Infection control. There's 48 pages in this sheet. And one of the questions is everybody using a single-use vial one time? So the surveyors might follow you around and watch what you're doing. So we all know what this looks like. This is a medical chart. And what I find interesting, in the lower right corner, it says, orders with unacceptable abbreviations will not be processed. This was picked up and signed off by the nurse. So it gets worse than this. This is one of the root causes of unsafe care. Because it was already stated, even the docs can't read the doc's handwriting. The nurses are much better at this than the docs. So Congress, who also sets your payment and the hospital payment, decided when we put the stimulus package out there, what we need to do as a country, as a nation, with a GDP of almost 18%, we need to do what every other industry in this country's done. You want to go on vacation, you can go on Expedia or Yahoo or whatever, pull up every flight, what it costs, where it's going, and how long it takes. But you can't pull up your patient's x-rays, so you order 3 more and more lab tests. And you don't know what the results are because you're too busy to stand at the fax machine, et cetera, et cetera. So Congress said, we're putting money out there because we need to take this healthcare industry and bring it up to the century that it belongs in. So you're in the throes of the transformation of the delivery of healthcare based on information. We are so behind the 8 ball in this industry. 10 years from now, you're going to look back, it's going to be knee-jerk, second nature for you to use a computer and not have to struggle because Congress built into the law certain provisions and requirements. Meaningful use, using it in a meaningful manner, the electronic exchange of information, and the ability to submit quality measures. Because in the future, your payment will be based on your ability to deliver quality care. The Affordable Care Act required CMS to develop the Innovation Center, and I want you to be aware of this because there is a lot of information that is coming into the Innovation Center, and we are looking for your ideas. And you are the healthcare leaders coming up. The rest of us are going to be retiring in another 10 years, hopefully. But for you, you will bring your ideas and your ingenuity and hopefully transform what in many cases is mediocre healthcare delivery. So these are many of our initiatives. The ACO, the Shared Saving Program. Now, we talk about ACOs. We have a pioneer ACO in Philadelphia that is a physician group. So think outside of the context of an ACO being a hospital. It's not about hospitals taking over. At the same time, you need to think about health care being delivered outside of the hospital. It's no longer an episode of care, because that's where much of the difficulty is in delivering good care. It's the continuum of care. Now, you're much more challenged in this area. Philadelphia ranks 67 out of 67 for the CDC, County Health Statistics. So you're behind the 8 ball, so you really are much more challenged to come up with how are we going to deliver good health care. For primary care, we have several initiatives you can see, including medical home. We have bundled payment suite. We know that the health disparities is a problem. We have a dual eligible division now. Partnership for Patients, Million Hearts. The Innovator Advisor Program. The ACO, there's several models, and I won't get into that now. But I do want to bring your attention to the Community-Based Care Transition Program. There's $500 million, and when it's spent, it will be spent. And this is for any healthcare organization that has a higher than average readmission rate, which you do, and I'll show you your numbers in a minute. And in another year, Jefferson, if you don't get those numbers under control, and I won't steal your thunder, they're not going to get paid 100%. We're going to start sweeping money back. But you are the primary care providers. I'm assuming you'll have your own clinic patients, yes? Or you will. So these are the patients that if you develop good discharge plans and stay in touch with those patients, you might be able to make a difference and reduce the overutilization of the emergency room at the same time. Here's your numbers. For acute MI, heart failure, and pneumonia, these are the PA average, which are higher than many of the other states in the United States. And here's Jefferson average. This is 06 to 09, the most recent data. It's posted on our website. Now, if you don't get those numbers down, we're going to start sweeping back money in 2013. So the Innovator Advisor Program. The applications can come from anyone in this room. And I had the opportunity to review applications, some from med students, some from residents, that said, we've got this problem. We've got these asthmatic kids that I want to keep at home and not back in the emergency room, or these elderly. And they wrote their application, and it's all about quality assurance, performance improvement for that healthcare system or for that population of patients. So think about it. This is really built in for any of you in the room that has something that you really want to pilot. So, wisdom on physician payment. There are many mechanisms for paying physicians. Some are good, some are bad. The three worst are the fee-for-service, which is what we have now. Remember, you go into a room, you're getting paid under Part B. The hospital is getting paid under Part A. The decisions you make affects what the hospital is making. Fee-for-service rewards the provision of inappropriate services, the fraudulent upcoding of visits and procedures, and the churning of ping-pong referrals among specialists. Capitation rewards the denial of appropriate services, the dumping of the chronically ill, and a narrow scope of practice that refers at every time. Salary undermines productivity. So this is what we have on the front burner for physicians. PQRS, you've all heard about that. ERX payments, high-tech incentive payments, which we're paying physicians to adopt EHR, as long as you're a meaningful user, and hospitals as well. Physician value modifier. Your participation, of course, this does not affect you. It will in future years, but how you do in 2013 in PQRS will affect how we pay you. Medical home, comprehensive primary care, multi-payer advanced primary care practice, federally qualified health center. So we're really churning out different payment models because we know the fee-for-service is not working. So, overcoming the barriers, we're going to adopt HIT. We're going to get rid of episodic uncoordinated care. We're going to enhance health system performance, but keep in mind, it's a continuum of care. You don't have to utilize hospitals as the primary base of the delivery of health care. That's accountable care. You work with your hospitals. You develop other ways to care for these patients. We need to integrate care. Thank you for being a part of this, for the hard work that you're doing to improve our nation's healthcare system, and we're ready to leap forward. Thanks to all of you.
Thank you, Dr. Thomas. I just want to let you know, I'm sure you're thinking of questions as you listen to this. If you'd like to write them down on those cards and pass them toward one of the aisles, Andrew and Greg will be circulating at the end of the comments to pick those up. And without further ado, Mr. Lubarsky.
Thank you. It's very nice to be with you here this evening. I'm Neil Lubarsky. I'm the Chief Financial Officer here at Jefferson University Hospital. I've been here for about 14 years. The opening presentation you saw I thought was excellent, and seeing that and knowing about the backgrounds of my colleagues here on the panel, I was firmly convinced there was nothing I could add to the policy issues there. And so what I thought I would do during this part of the discussion is tell you about some things about Jefferson University Hospital, and some data and things like that. But just a few things. When I first got here this evening and I met with Alan and Andrew, and then I saw some of you come wandering in, and I noticed a difference in the way they're dressed versus the way you all are dressed. Now, Jefferson is a pretty conservative organization if you work here on the business side, in hospital administration and university administration, so this is sort of like the way we dress. It's probably a little bit stiff, but that's kind of the culture. So I complimented them. I was and asked them why they were dressed so sharply, and they said, well, we want to impress the panelists in case we need to apply for a job with you guys. So you guys are doing fine so far. Right? I'd also like to just get a little survey so I get some sense of the audience here. How many of you have an iPhone? Who has an iPhone? Okay, and who has an Android? Okay, and who has a BlackBerry? 1, 2, 3. So some of it is age-related, and I don't know what your problem is, pal. But let's talk for a little bit about Apple, because they're in the news a lot, right? So an iPad today costs about $600 or so, I guess, give or take, right? Just so happens it's roughly about equal to a share of a price of stock of Apple. I don't know if any of you have ever, I'm sure a lot of you have been to an Apple store. I don't know if you've been in this area, but have any of you ever been to the Apple store on Fifth Avenue in New York up near Central Park? Anybody ever see that? It's an absolutely amazing place. I haven't been in the store, but I've been by it. I was at a conference up in New York on investments back in the fall, happened to walk by it, and I was struck how on a Sunday night the long lines leading outside of the store. I learned that the sales of that Apple store are greater than the sales in Bloomie's or Macy's in New York, which I thought was rather profound. So this is a company that really gets it. So hearing all that, and knowing that there's a lot of Apple fans in the room, so if we were to tell you that after tonight's session, when you walk upstairs there and check out, that Alan and Andrew will give you either your choice of an iPad or a share of Apple stock, which would you prefer? So who would take the Apple stock? Okay, so I won't ask about who would take the iPad then, all right? So what you've told me is that you're all capitalists. All right? So remember that. Remember that for the rest of this discussion. Okay? All right. So let's talk a little bit about Jefferson University Hospital, which in this case also includes Methodist Hospital in South Philadelphia, which I'm sure many of you are also familiar with. But just to give you some sense of the lay of the land, Jefferson University Hospitals, I will call it, has about 48,000 inpatient admissions per year. An average daily census of about 750. During the week, from Monday to Friday, that census might be as high as 850, and then it can be lower on the weekends. We have about 110,000 visits in our emergency departments. There's 3 emergency departments, one here at the main campus, one a block away in the Jefferson Hospital for Neuroscience, which is an ophthalmology emergency room, and then in South Philadelphia at our Methodist Hospital campus. We probably have, and I'm guessing on this one, but maybe about 3,000 patients that are admitted to observation unit status in our hospitals. I expect that number will continue to increase as our business changes. And we have about 7,300 full-time equivalent employees. So that would probably translate into maybe closer to 9,000 actual bodies of people that work at Jefferson. And when you combine that with the people that work in the medical school and in the university and in Jefferson University physicians, that 9,000 probably grows to something in excess of 13 or 14,000. And Jefferson is one of the largest non-governmental employers in the city of Philadelphia. The largest is still probably the University of Pennsylvania. Included in that 7,300 full-time equivalent employees, we have about 800 residents and fellows. And then in addition to that, from a non-employee perspective, there's medical students that are rotating through the hospital as well. The larger programs at Jefferson here downtown are in orthopedics, neurosciences, cancer, and cardiology. Very big programs here. The budget for our organization, the part that I'm responsible for, is $1.6 billion. Nowhere near the $2.7 trillion that you saw up there, but $1.6 billion. So when we're in meetings with some people and try to put some context around, well, what does that mean? So the way I'm fond of describing that is that every day that we put the key in the door, we spend about $4.4 million. And some people that I work with will say to me, we'll spend that even if we don't put the key in the door, which is true. So it's a very expensive and it's a very high-cost operation here at Jefferson. So what's a typical day or a typical week like for somebody like me that works in the business end? So first I would say that finance is how I'm trained. It's probably the easy part of my job. The part that I find most stimulating is working with clinicians, speaking with people like you, interacting with my panelists here. And that's really the fun part of my job and the part that floats my boat and helps me do my job better. And for that I feel especially fortunate to be able to work at a place like Jefferson. So yesterday, Monday morning at 8 o'clock, we had a meeting with our finance committee. So organizations like this were organized as a not-for-profit organization, but from a corporate perspective, it's set up not unlike a public company. So we have a board of trustees, which would be like a board of directors. So we met with the finance committee of the board of trustees yesterday morning to go through our financial results, our statistics, some discussion about the budget for the upcoming year. We have a big budget presentation that we have to do for them on May the 23rd. We then, after that meeting, had a meeting with some other people in our organization that work at our corporate headquarters. There's a Jefferson Health System, which is the parent company of the University Hospital organization here, as well as Mainline Health, if some of you have heard about that. Mainline Health is like Lankenau Hospital, Bryn Mawr Hospital, Paoli, and so on. And the McGee Rehabilitation Hospital is also part of the Jefferson family. So it's a big organization, and so we spend a lot of time with dealing with the parent company organization, and they provide us a lot of guidance on quality targets and metrics, financial targets, and so on. So we had to spend time with them yesterday. Today I had to also spend time preparing with people that we work with at PricewaterhouseCoopers, because we have a meeting with our audit and compliance committee coming up next week. And so there's a lot of information that needs to go to them. And I was asked to sit in on a discussion today with some people internally who are getting ready for a meeting with the quality committee of the board to take place over the next couple of days. And before I came to this meeting, I was at a monthly meeting of our clinical department chairs, where I gave an abbreviated report on our financial and statistical results, because I wanted to be sure that I got here on time. Earlier this afternoon, I was at a meeting with folks in our decision support area who have been hard at work working on the implementation and installation of a new cost accounting system for Jefferson. We have a cost accounting system. We've had one since about 1984. That system needed to get upgraded. We had a pretty good system that was still widely used, but needed to upgrade so we could handle the transition to working in a value-based type system. It was a big project, and the people have worked very well on it. I have a meeting tomorrow morning on ICD-10. You've heard of ICD-10? And so that's the new coding system that we're going to have to use starting is it 2014? Did they set that? Is that like cast in stone now?
I think we're pushing for 2014. You know, we pushed it from 2013.
I know that. So we have a lot of people that are teed up, that have already spent a lot of time to get Jefferson ready for ICD-10. It's a very big project. Some people have described it as if you take, some of you might be a little bit too young to remember some of it, but if you remember Y2K, some people feel that preparing for ICD-10, the investment required for ICD-10 is like taking Y2K and HIPAA and putting those things together, and it's like that big. But order of magnitude, Jefferson will probably spend $20 million preparing for ICD-10. Who's going to pay for that? All right, so we need to think about that. So Jefferson, so we're about a $1.6 billion budget. Our operating margin tends to be in the 3 to 4% range. So after everybody gets paid, after the lawyers get paid, and the malpractice things get paid and all that, there's 3 or 4 cents left on every dollar. So it doesn't sound like a whole lot. And so the business that we're in right now, we're in a fee-for-service business. And so we're very interested in volume and smart growth. But as you heard from some of the discussions, that's going to change. And so how will an organization that has a lot of fixed costs, that manages to run on a 3 to 4% margin and is well liked by the credit community, Jefferson has a good reputation there, what will it be like transitioning? And how will we manage through that financially? So I'll share with you some information. I'm just going to use broad ranges about how much we get paid for different types of procedures by different types of payers. I'll try to keep this simple. Joint replacement. We do a lot of joint replacement here. So the garden variety insurance carriers might pay Jefferson, the hospital, these are just hospital payments, might pay Jefferson somewhere in the high 20s to low $30,000 range for a joint replacement case. Those patients are usually here for 3 days. It's now going down to actually about 2 if they're healthier. The Medicare program, and this is not a shot at the Medicare program, but the Medicare program for that same procedure pays us maybe $17,000 or $18,000. And that the part that the governmental payers pay to us, you could sort of figure out how to get access to that information that would be publicly available. So there's a significant difference in how much the private carriers pay versus governmental. CABG with cath with complications. So cardiac bypass procedure. The insurance carriers in this marketplace might pay us somewhere in the $60,000 plus range. The Medicare program pays about $56,000. The Medicaid program pays about $38,000. Kidney transplant. We have a very big program here in kidney transplant also. The insurance carriers pay us a significant amount of money, maybe sometimes $80,000 or $90,000, sometimes more. The governmental payers pay $25,000 to $35,000. In the outpatient side, in the emergency department, so in the emergency department we get paid their levels of 1 through 5. The lower the number, the less acute the patient was. So like an ED level 3, let's use that as a placeholder. Insurance carriers might pay Jefferson maybe anywhere from $700 to $1,000 for ED level 3. The governmental payers pay about $150 to $200 for that. And lastly, angioplasty. Angioplasty, the carriers might pay us in the $4,000 to $5,000 range. That is one which is pretty close for the federal payer on the Medicare side. So when you think about a business that runs on a 3 to 4% margin, and you think about the disparity I just described to you and how we get paid, what happens if we're moved to a single payer type system? And if you think that the insurance carriers will tend to, what they'll want to do is, they'll view the government as the prudent buyer. I would too. And, will they try to say that, we need to move towards that level of payment? And if that happens, and although I'm not quite ready to retire, but that might convince me that it might be time to hang up my boots. Because that will be very, very disruptive for this business. And it won't affect just hospitals, it'll affect doctors and everyone else. So that's something we're really watching. Are we going to migrate to a Medicare payment world, or is it going to be some blend of something in between? And that remains to be seen. So what are some of the things that Jefferson has done to prepare for this environment, for this transition to a value-based type system to a more consumer-driven system? Jefferson has done a lot here for the past few years. And for many of us, it's been like drinking out of a fire hose. So a few things that we did. We changed the way we evaluate our staff. Historically, we used to evaluate our staff just based strictly on the performance, which was their technical skills. We added a component that is just as important now as their technical skills, which is their adherence to the values of the organization. And those values are service, collaboration, ownership. Think of ownership as being like accountability and respect. Because those are the types of things that organizations need to be good at if they're going to compete in a more consumer-oriented, value-driven type business. Several years ago at Jefferson, through the hard work of our nurses, we received magnet designation. And that's now up for reapproval. Jefferson has several people working on in the Baldridge type program, which is an indication of performance excellence, and it's a goal that Jefferson has set for itself. We've been in a long-term contract with GE Healthcare for the past several years, helping us with management techniques in Lean, Six Sigma, workout, change acceleration, and so on. We've trained many Jeffersonians that work in the hospital and some in other parts of the campus as well. So we have people here at Jefferson that are black belts and green belts and yellow belts and all those kinds of stuff. And so they're trained to help us now think differently about processes and systems to manage projects and things like that, which is very important. We use a balanced scorecard approach to really manage our business. Organizations like this have so much data, so much information, so many sometimes conflicting priorities. We determine what are the most important things for the organization, what are the goals. We track those on a balanced scorecard in the areas that we think are going to drive value in areas like finance, quality, people, growth, and service, and monitor our performance against that. The way the executives at Jefferson are compensated is based on, in part, adherence to and achievement of those types of goals. We spend a lot of time with strategic planning on a 1-year and 3-year basis. So we do a 3-year plan and a 1-year plan, and each year that gets refreshed. The people outside of the clinical area, the people at Jefferson that have the hardest job are the IT people, because the IT systems in this industry are so fragmented and nowhere near ready to do the things that we need them to do, and they have a pretty tough job. We have invested a lot of money the past couple of years, and I told you before about upgrading our cost accounting system. Also, we've upgraded our supply chain information system. That went live last July. And we're spending a lot of time with talking about physician and hospital integration, because those two parts of the campus need to work more closely together in order to be successful. So the other thing I would point out is that finance and quality, people that work in finance and people working in quality at Jefferson are working more closely together than ever. And it's really been a lot of fun, and we're even actually sharing some staff. And now we're fighting over them because the finance people want the quality folks. The quality folks want the finance people. I wonder if one day it'll all be one department. So you heard in some of the earlier comments today about ordering of tests and documentation and things like that. So I'll conclude my remarks to give you something to think about regarding the cost of ordering a test. Okay? And let's pretend that the test was unnecessary. So let's use a radiology test or a lab test, for example. So is the cost of ordering that last lab test, which wasn't necessarily supported by evidence-based medicine and evidence-based practices, is the cost of that test the 25 cents or $2 for the reagent that they needed to use in the lab to do the test? Is the cost of the X-ray or imaging study that was ordered, is it the 2-cent cost for the space that it takes up in the PAC system? That's not the real cost. The real cost is the frictional cost surrounding the ordering of that test and then what happens afterwards. So if a patient is in a bed, we have 750 patients in a bed on average every day, but during the week I said maybe 850. When a test gets ordered, so a test has to go in the system, if the patient then needs to be transported from a nursing unit to where the diagnostic procedure might be performed, or if there's a lab specimen, the lab specimen would probably be drawn in the patient's room, but that has to be transported. But using the X-ray example, patient needs to be transported to radiology, right? Patient waits there. Procedure gets the imaging study gets done. Patient then may have to wait for the transportation to go back to their room. In the meantime, there may have been a shift change in the hospital where the nurses turn over, and then we're waiting for the results to come back from that study. Then it's got to be read by physicians, it's got to be read by the resident, read by the 3rd year, the 4th year, you name it, right? And so the cost of the unnecessary tests are all those frictional costs that I described to you. And those are the things that you should think about. It's important to have a systems-type orientation. It's like dropping a pebble in a pond, okay? And it ripples through the entire organization. And then ultimately for Jefferson, what happens is the patient movement slows down, the throughput slows down, and we get paid basically rates that are prospectively determined. So those rates I described to you before, that's what we get paid. And 99% of the time, no more. It doesn't matter how many days the patient stayed here. So for us, what we're watching for is we're looking at those frictional costs and the opportunity cost by not being able to turn over the bed. Because if we can get another joint replacement patient into the hospital, that might be $30,000 that the hospital could earn on the revenue side that we lost the opportunity for because the bed was tied up. We were too tied up. And so it's important for you to think about that, to talk about it with your colleagues. And one of the things I like to say to people at Jefferson, it's always important to have friends in finance. You'd be surprised what they can do for you. Enjoy the session.
Thank you, Mr. Lubarsky. And our final panelist, Dr. Rosko. Again, if you have questions, please pass them to the aisles, and we will get to your questions very soon.
My slideshow.
Oh, yes, pardon me. And if you learned anything from this PowerPoint, spelling does not count third year. Please forgive me.
Good evening. It's really nice to be back here. I was reflecting earlier, back in 1972, I had the opportunity to shadow a vice president at Jeff for about 2 weeks when I was doing my MBA at Temple. I was only about 15 at the time, though. I was a child prodigy. More recently, about 15 years ago, David Nash invited me over here. Do many of you know David Nash? David, at the time, was the director of the Health Policy Unit. Now he's gone on to become the dean of the School of Population Ecology. I thought the agenda was to develop a research collaboration between Widener and Jeff, but David had a different agenda. His agenda was to have a dual degree program in which in 5 years a student would get an MD from Jefferson and an MBA from Widener. And he's a very persuasive person, but he didn't have to do a hard sell with something. I was on board immediately. And so I've been teaching Jeff MD students for about 12 years on the Widener campus in Chester. I see at least one up there, Stu Green, so it's nice to have at least one friendly face in the audience here. So I'm going to be giving you an economic perspective on things tonight. Now, every country in the world faces three major problems, and as an economist, we're taught to deal with trade-offs. So the three problems deal with quality, access, and cost. With quality, and Barbara mentioned some of these things already, that only about half the patients at best, and depending on the study, it might be less, it might be a little bit more, get the recommended care that's based on evidence. There are numerous preventable deaths. The National Institute of Health published to Errors Human slightly more than a decade ago, and they reported that over 100,000 people per year die because of medical errors in hospital. To put that in perspective, that would be the equivalent of a jumbo jet crashing every other day. And if that was happening in the airline industry, the uproar would be incredible, but we sort of take that as a given here that death it's an imprecise art and people die. Well, 100,000 is way too many. Regarding access, we have between 45 and 50 million Americans without health insurance. I've been a visiting scholar at the University of St. Andrews in Scotland, and they think we're a bunch of barbarians over here. They have a national health system, and it just boggles their mind how we can let people go without having guaranteed access to health care. But actually, they have a loophole, too, and they use the emergency room as their primary care doctor, which, of course, is a very inefficient thing, and it adds up to that $49 billion a year in healthcare expenses that the uninsured have. The other problem with uninsurance, lack of insurance, is that they're at much greater risk of dying than insured people. So it's not only a costly thing, but it raises the incidence of premature mortality. The cost information you've seen before, so I don't need to go into that. But here's a slide that gives a perspective on how much we spend against how much other countries spend. And in economics, there's a relationship. You should do something as long as the marginal benefit exceeds the marginal cost. And you can look at this curve here as a marginal benefit curve. And the vertical axis could be translated into the marginal benefit, the change in life expectancy, and of course the horizontal axis would be the change in cost. As you can see, the United States has a negative delta benefit and a very significant positive delta cost. So we're spending a lot more and we're not getting much for it. Clearly, we're not getting a good bang for the buck. And to put this in perspective, here's some public health statistics. We rank 26 out of the 34 member nations of the OECD in life expectancy, 25th in maternal mortality, and 30th in infant mortality. We have all that despite the fact that we spend a lot more on per capita health care than any of these countries. There are also variations in the relationship between care and outcomes in the United States besides the international perspectives. And as we can see, this graph here is if we're doing regression analysis, the R-score would be close to zero. There's really no relationship between Medicare expenditures per beneficiary and the overall quality of health care. And McAllen, Texas would be a good example. They're probably, well, Texas is up here with the really high cost and the low quality zone. So we spend this $2.6 trillion per year in health care. More than 3/4 of it is spent addressing the medical impacts of non-communicable preventive chronic conditions. We only spend 3% on preventing these conditions. And this is a big underinvestment. There are big opportunities here because the people with chronic illness, there's the old 80-20 rule or the Pareto principle. 20% of the patients account for 80% of the cost. And these people, the high users, have multiple chronic conditions, and we really are not doing a very good job at this. And there's a great potential to deal with it. An estimated 80% of heart disease and type 2 diabetes incidents, 40% of cancer incidents could be prevented by exercising more, eating better, and not smoking. These are not high-tech, high-cost solutions. These are relatively easy things to do, at least from a cost and resource perspective. Now, the equation I have here is total expenditures equals price times units of service. So when you're trying to figure out, how do we get to those trillions of dollars? We have high prices and high volume. And so the analysis that we need to perform is what causes the price to go up and what causes us to have more units of service. So I wouldn't be a good economist if I didn't have a couple of supply and demand graphs in here. Equilibrium price is determined at the point where supply equals demand. Oh, I'm missing something here. Oops. I should have a line that bisects A here, so just imagine that, and we're shifting that line from D to D prime. So what causes the demand curve to shift? Most people, unless they're hypochondriac, they don't want to buy health care. They don't demand it as we do with normal goods. They need it. And what factors have shifted the demand upward and to the right? Well, we've got an aging society. I'm part of that baby boom generation that is consuming a lot more health care. We're prone to chronic problems, aches and pains, and more serious problems. And believe me, in terms of the chronic problems, I'm certainly very well of that situation with aging. We have greater incidence and we respond less quickly. We also have things like defensive medicine. Doctors are concerned about malpractice lawsuits, so they may provide extra tests, not because they think the evidence suggests it or the patient really needs it, but because they want to protect themselves. We have risky behavior. People smoke too much, they drink too much, they have unprotected sex, they share needles, and so forth. There's also bad behavior. We have we have the highest incidence of obesity in the world, both among adults and amongst children. And that results in diabetes, heart problems, orthopedic problems, a whole host of problems are associated with that. All these things serve to shift the demand curve up and to the right and moving us from point A to point B, where we not only have a higher price, but also have higher units of service demanded. And I apologize for the small print here. The points in bold are the most important ones. This column here shows percentage of population that is obese. By that I mean a body mass index of greater than 30. In the United States in 2004, the percentage was 30.6. The median for OECD countries was 12.9%. So we're almost 3 times greater than the median for the rest of the industrialized countries in the world. So, clearly that's given rise to the increased demand for healthcare. On the other side, on the supplier side, we've got cost-push inflation. And factors that could shift the supply curve inward would also result in a higher price. Anything that increases the cost of doing business could shift that supply curve inwards. So this could amount to things such as having more inputs per day, more expensive inputs. As you're getting the high-tech equipment, you have to get more highly skilled personnel to run the high-tech equipment, and they command a higher salary. Of course, on the demand side, we have defensive medicine. On the supply side, the counterpart is increased malpractice premiums. So all these factors tend to shift the supply curve inward. And here's another slide that shows the utilization of high-tech procedures in the United States and other countries. Coronary bypass procedures per 100,000 people, U.S. figure 160. Median for the rest of the industrialized country, 60. Coronary angioplasty, 426 per 100,000. Rest of the industrialized world, 158. Patients undergoing dialysis per 100,000 people, U.S. 159. Rest of the industrialized world, 45. Bone marrow transplants per 100,000 people, 5.1% U.S., 2.9 per 100,000 people in the rest of the industrialized world. Not to say that this is not all beneficial care. Indeed, I saw an article in Health Affairs yesterday that for some forms of cancer treatments, the extra expenditures that we have compared to the OECD countries actually are well justified, that the benefits outweigh the cost. But there's a lot of fat to trim out there, and I really was glad to hear Neil's presentation, because besides health economics, the other course I teach is process improvement. In fact, one of my former students, I don't know if you know Patrice Miller. Patrice has moved on to be a vice president here, but in her former life she was the director of performance improvement, and I'm really proud of her performance. And in my process improvement course, I teach things like Six Sigma and Lean, because one of the solutions to our problem is to have a more efficient and effective healthcare system. And those tools are certainly part of the solution. They're not the whole answer. I think part of the answer is better treatment of the chronically ill, but there are a number of different solutions. Thank you very much.
I have a request to the panelists. Would it be possible to perhaps stay an extra 15 minutes so we can extend out the question and answer? All right, this is the portion that we're excited about. We want to hear from you guys. So the way this is going to work is we will read a question from the audience, and then we will switch back and forth between that and the microphone. So if you'd like to get up to the microphone and ask a question, we'll do that too. The first question, how are payments determined? Why is there a difference based on who is paying? It's open to anyone.
Well, Medicare payments are based on what Congress determines. Every year, the rule comes out for public comment on the physician side as well as the hospital side. So when we saw the differential in price, Congress is setting the prices. We operationalize the law, but we're not deciding that we will only pay 2/3 of what a private payer would pay. This is all. These are the people you're putting into office.
Question from the back?
Well, I mean, that wasn't my question, but I feel like the next follow-up is like, well, where do they get those numbers from? Is Congress just kind of like roll a dice and say, all right, we're going to pay, we want to pay $3,000 or whatever? Like, how do they come to those numbers?
Well, on the physician payment side, it's based on growth. So if growth slows down, physicians are paid less. And as you're probably aware, hearing the disgruntled practitioners in the hallway of Jefferson, and rightfully so, they've had this looming large payment cut. Now it's almost 28%. And every year at the 11th hour, Congress will stay that cut for another 1 month, 3 months, or 1 year. What we need to do, and what you might want to do, is look at what MedPAC recommends to Congress. For the most part, Congress doesn't pay any attention, but MedPAC wants to reform how we pay. What we're doing, as you saw some of the different payment models, we are changing, and in the next several years, we will change the way we pay. Whether we get rid of fee-for-service, that might be 10, 15, 20 years, or even 5 years, depending on what happens with this next election.
I'd like to follow up on that. Historically, Medicare and a lot of other payers paid physicians on the basis of usual and customary charges. And what that resulted in was great inequities by discipline and by region of the country. There's a lot of variation in that. So a very extensive cost accounting exercise was conducted, and out of that, the resource-based relative value unit system was developed to reduce some of those inequities. On the inpatient side, Part A, when Medicare first came online, it was on the basis of reasonable cost. And that was very inflationary because if a hospital had greater cost in 1966, they'd get greater reimbursement from Medicare in 1967, so there was no incentive under this retrospective cost-based system to contain costs. So they thought if retrospective cost-based reimbursement was the disease, the cure would be the opposite of prospective payment system, in which they use the diagnosis-related groups.
So I would add that what happens then on the commercial side is that it's more market-based and competitive. And so if you went back to the Philadelphia marketplace 20 or 25 years ago, I think you would have found like 86 or 90 independent hospitals. Now there's really, you probably count on one hand how many truly independent hospitals there are. In this marketplace, there are two big insurance carriers, Independence Blue Cross and Aetna, and then there's a few others, as you know. Those big carriers are competing for members. So it's members times a premium that the members pay, which typically comes from an employer, and that's their revenue stream. Aetna is a stock-based company, so they have a profit motive. It's a little bit different with Independence Blue Cross, but ultimately, what's happened because of the challenges with governmental reimbursement, then that forced healthcare providers to consolidate, to integrate, and to get bigger. And so they wanted to become more like the Walmarts so that they could extract a better price from the commercial payers. So what happens is the commercial payers know how much premium they can charge in the marketplace because they have to compete for members. And they also know, based on the footprint of the University of Pennsylvania health system or the Jefferson health system, how much that system can demand or extract in terms of payment for its services, because you need to have those big providers in their network. Those insurance carriers know what the most that their medical loss ratio can be. The loss ratio being, I'll just make it up, say 80%, meaning that for every premium dollar they collect, they can pay out 80 cents in claims, and maybe they'll use 12% or 14% for administration of the business, and the rest becomes profit. So that's sort of how it works on the commercial side.
In the follow-up, another question was, a student asked about the AMA-RUC committee and the importance they play in setting the baseline level of repayment.
Well, we work very closely with the AMA, in particular regarding the codes. And many of the codes that come out, many of the newer codes are written by the AMA. We're also working on a lot of the measures. But again, Congress does not follow what AMA or MedPAC is recommending to them in terms of payment. So they're limited in the context of the kind of power that they have, even though they're a large organization. I just want to make one more point. 20 years ago, insurance companies could insure it across state line. That's a relatively new rule that you can only insure within a state, which is interesting because the argument sitting before the Supreme Court now, and they've already made their decision, is regarding insisting that everybody have health insurance and whether they can cross state lines. But ultimately, what we do need, back to the cost of health care from the private payer, what we do need, because we already established that most of us here are capitalists, we need more competition. And when that law came into effect, that competition left. The hospitals were forced to negotiate with that carrier within their state and not across state lines.
Before we get to another card, does anyone want to ask a question from a microphone or in the back?
Why don't you have physicians more involved in deciding payments rather than business people? I mean, how many physicians are actually involved in the decision as to how much is paid to them when they're the ones delivering the care and they know what it should cost?
Are you talking on the public side in Medicare, Medicaid, or private?
I'm talking Medicare, Medicaid.
Medicare, Medicaid, we have, I'm the chief medical officer for 6 states. We have 10 regions. We have a chief medical officer, and they call us chief because we're the only one in each region. Medicare, Medicaid only has about 5,000 employees total because we pay our contractors to pay the bills. But in central office, much of the payment policy, and again, we are charged with operationalizing what Congress decides. We need more docs in Congress, not more docs in Medicare, Medicaid necessarily. At this point, we need more lawmakers that are sensitive to the delivery of health care and not necessarily attorneys, so to speak, that maybe have other interests.
Sure. The other thing that affects it is that what moves people from Congress, the representatives and the senators, is are there the people in their districts? Do they have access? And if they believe that the people in their districts don't have difficulty with access to care, it makes it difficult for them politically to step up to the plate and argue for more reimbursement. So it's a very difficult issue.
Okay, going back to another card, I'm going to combine two questions here, so please forgive me if I butcher them together. This relates to the cost takeoff in the 1980s, 90s, and 2000s. One student talks about the scarcity of health care, the demographic differences between the U.S. and other countries that were touched upon earlier, the variability and quality of care, insurance overhead, as well as high-cost tests and procedures. And the question is, what accounts for that break in 1980, 1990, and 2000?
Well, DRGs came in the early 80s, and that changed payment because cost, in particular on the A side, was really spiraling out of control. I was an internal medicine resident between 81 and 84, and the big deal when I was a resident was bedside echo. And that's really what's driven cost, technology. And keep things in the context of where we have been. 50 years ago, when was the first cardiac care unit in the United States? 65, up at Harvard. My grandfather was admitted with an MI in 65. He was allowed to sit in the hospital bed and smoke his pipe. And patients were still smoking in hospital beds in 79. So things have radically changed. What has driven the cost is really technology. And again, as was said before, the pen of the doc.
This question is specifically for Dr. Connors. It talks about the primary care shortage, physician shortages in general, and questions the driving, their argument is the driving reason behind students choosing specialties over primary care is large student debt. Is CMS looking into this issue?
Yeah, we are. If you reflect back on the slide that I showed, there's several payment models for primary care. As we speak, we actually bumped up primary care payments between beginning of last year and 2016 by 10%. It doesn't sound like a lot, but it's a start off. At the same time, we're looking at and constraining some of the payments for some of the high procedurally related type of specialties. In particular, we're looking very much at radiology, and we pay radiologists and other specialists such as ophthalmologists. So you're going to see more of a balance of scale as we go further on. At the same time, I will say, though, that we are looking at incentivizing hospitals, for example, to train nurse practitioners, physician extenders, because does all primary care need to be delivered? Can you be a more effective primary care physician when you're not just on that wheel, spinning your wheel and churning volume to make ends meet? If we pay you more and we pay you for your cerebral contribution, some of the basics can be taken care of by your, I hate the use of this word, but your physician extender.
So the fee-for-service system that we have now is a totally irrational system that is behaving perfectly rationally in the way it was set up. Remember, you're all capitalists, right? Ultimately, you all behave what's best for you personally. And so the way the payment systems were set up, and clearly in hindsight they were perverse, it rewarded procedure-based testing and procedure-based disciplines and things like that. Now we're talking about prevention and wellness, and if we take care and minimize those chronic diseases on the front end, it'll take the cost down for the system overall across large swaths of the population. And I believe that. Who wants to be sitting with me in a discussion where we have specialists, one who makes $650,000 a year, and another one who makes $800,000, and another who makes only $400,000, and then you have the primary care practitioner who maybe makes $100,000. And who wants to be sitting there with us when we start saying, okay, this is how much is going to go from you to you? And do you think the administrator will get out of that discussion a lot? And that's what we're having to face up to.
We currently have 50 million people without health insurance. The Affordable Care Act is supposed to deal with that. As I said before, those 50 million people get a lot of their health care in the emergency room because the law says you cannot deny emergency treatments. And parenthetically, I would add that about 70% of the care in many emergency rooms is not truly emergent care. It's just patients that show themselves there. So if it gets to the constitutional crisis, and we do have the Affordable Care Act, and we now have 40 million people that have health insurance, where are they going to get it? We don't have enough primary care doctors, so the ironic thing is they may still have to go to the emergency room. I certainly wholeheartedly endorse Barbara's idea that we need to expand primary care doctor pool, but we also need to have more nurse practitioners and other types of physicians extenders to increase the productivity of physicians. That would be a much more rational economic approach. And research, by the way, has shown that for patients with chronic conditions, that the quality of care provided by nurse practitioners is maybe superior, if anything, in some cases.
All right, this is a question to Dr. Rosko, but I'm sure Mr. Lubarsky and Dr. Connors will like to comment. It refers to the cost conundrum again in physician-owned hospitals. One argues that there's a policy study that says that they perform better in certain procedures, kind of the higher-level procedures, and other studies show that those incentives lead to increased utilization because the doctors is incentivized to order more tests and more procedures. Where do you see the physician-owned hospital or physicians in administration or physicians' incentives in the ACO model or other models going forward?
Okay. The answer to the physician-owned hospital question, or the charges, is yes to both. Yes, they have been shown in some cases to act like focus factories. If you specialize in something, you can master it and do it better. There's the learning by doing phenomena. And also they can do it better because they maintain their proficiency by having higher volumes of certain types of surgeries. So they can indeed have some good outcomes from these types of facilities. On the other hand, it's been charged by the larger general hospitals that they engage in cream skimming, which means they don't take the uncompensated care, they take the insured patients and leave the uninsured patients for the general hospitals, which puts them in a unfortunate situation. In terms of accountable care organizations, there are many ways in which you can structure it. So that can go in any type of direction. You can have a hospital that's an accountable care organization. You can have an integrated delivery system as an accountable care organization. You can have a multi-specialty group practice. So it can go in any type of direction, and I don't care to speculate too much on that right now.
And along those lines, Mr. Lubarsky, what are your thoughts on physician involvement in the administrative side?
Well, I have mixed emotions about it because I work closely with many physicians, and many of them are quite entrepreneurial. So I guess a few things to think about. Perhaps they could be more successful in areas that are less densely populated. When you think of a region like Philadelphia, Pennsylvania is an old state, as I understand it, and many in the Northeast or in the upper Midwest. And so what happens if, heaven forbid, you have a patient that was taken to an emergency room at one of these focus factories? Because I don't understand all the rules, but as I understand it, they'll have like a sort of a makeshift emergency room. And God forbid somebody coded there, and they really weren't equipped to deal with it. Could you imagine what the PR on that would be in this marketplace? Remember the strawman congressmen or senators that I described before, how will they react? So I think that really needs to be carefully thought through. But I would agree that organizations that specialize in high volume type procedures tend to be better at it than other organizations that just dabble in it.
This is another combination question. It's looking at the availability of tests, in the high-tech hospitals that we work in, and questions what role does medical education whether it be at the first through fourth year level or in the residency program and training physicians, and that in conjunction with availability tests play in training physicians toward reflexivity or not ordering a test or a procedure.
Yeah, I think Stu Green could answer that question up there because he had that on the final exam in my course. And you might remember that one of the reasons why teaching hospitals are more expensive is that it's a learning facility for medical students and graduate medical education. So they learn by doing. They're curious by nature, and they will order some extra tests. But that's part of the medical education process, and I don't know if that's necessarily a bad thing. They have to learn someplace. Research has also shown that medical education is a drag on the productivity of other workers, especially nurses, because nurses are always being asked questions by medical students. So instead of doing their normal work with patients, they're spending a lot of time with doctors in training. Again, that's not necessarily a bad thing, but it's a fact of life that it does cost the cost of health care in academic medical centers to go up.
And I think it's a work in progress because I think clearly what the governmental payers are telling us and what the commercial carriers are telling us is that the rate of price increase is going to slow down, if not have just an absolute decline in your reimbursement rate. And to me, what it looks like is that for the big teaching facilities, is that we're on a collision course of economics with the mission of training and discovery. And this is something that's going to play out over time, and I think it'll be very interesting to see ultimately where that lands.
And I think integrated into your medical education, if you can go and work in a federally qualified health center where you don't have access to those tools, where you have to listen to the patient, where you have to think, where you have to use your hands, the old kind of medicine, that could help kind of keep you from just knee-jerk ordering, because ultimately your payment will be based upon what it costs to take care of that patient. When we've aligned the inpatient and the outpatient and those readmissions together, that's going to be the cost of what it costs when you practice. So what you need to do is get out there in those rural areas or go into those FQHCs, and there's a bunch in Philadelphia, and hopefully you are connected with many of them. Get out there and learn how to practice in the real world, because many of you will not be in academic medical centers and you will not have access to this technology.
Question from the audience?
Yeah, this is for Mr. Lubarsky. You talked a lot about the expense of the physician pen. I'm curious that as the guy who's responsible for paying for the additional tests that they order, does that frustrate you personally? And how much effort do you put into getting physicians to change their behavior?
Wow. So I think the way I would answer the first question is, in another area where we spend a lot of money, and Jefferson has a community responsibility to provide care for those that can't afford it, charity care. We provide a lot of that to the community, and sometimes when we get to a certain threshold, I have to sign off on it, and I've signed off on some pretty big ticket charity care items. And so when I think of those items and the things that I've done that I believe are part of the mission of the organization, I view those things as being very, very important part of what we do. And it helps me to perhaps not feel so bad about the first thing, about the excessive ordering of the tests. In terms of what we're doing with the physicians, so what we're talking about now is a concept that is now been blessed by the regulators called co-management. And so, and I'll describe it informally as like a shared savings program. So if we can, in working closely with the clinicians, identify opportunities for cost savings by standardizing in supplies, by embracing more clinical pathways to reduce variation in outcomes and costs, that as we succeed in that, we could economically share some of that benefit with the physicians. And historically, that had been hard to do from a regulatory point of view. It's easier now, And there's models on that we're studying, and I think we're going to see a lot more of that in the future.
Question?
Thank you all for coming and taking some time out of your day. There's been talk on and off in Congress about transforming Medicare into a voucher system. I was wondering what you guys view as that going in, whether from the hospital perspective, if Medicare is giving vouchers to private insurance companies, if you expect to be reimbursed more, if that's favorable for you, or from Dr. Connors, how you view that in regards to access to care issue.
Oh, I mean, we could talk about that for the next 6 hours. Whether we go there or not, I don't think that that's really where we're headed in the immediate future. Simply because the first thing we have to do is ensure the 40 or 50 million people that are uninsured. To start handing beneficiaries vouchers when they have difficulty maneuvering the healthcare system as it is, I think is really going to be very daunting. So I don't see that as happening in the near future.
Okay, this is another question. Another question?
It's not follow-ups if you want to do that.
Okay. So please don't take this as crass. I'm quoting this directly. It's been said that the cheapest health care for the elderly is a bullet. Although I'm sure none of you agree with this, what do you think the best approach is to lowering costs in the elderly and end-of-life care?
Well, let me take that since I work for Medicare. Unfortunately for the country, Don Berwick was our administrator for a little over a year. And he finally left Medicare simply because he couldn't get past the misinterpretation of his statement that what we need to render in particular to the elderly is the right care. We tend to do everything we can and not step back and say, what are we doing? Is this the right care for that person? Does that person need to be on a vent? Do they need the trach? Do they need the stent? Do they need the repeated surgeries? What is the quality of care? What are we doing to our elderly? So, for physicians, and we are incentivizing physicians through PQRS, one of the measures is having an end-of-life care discussion with your patients when they can have those discussions. Engage the family at that time, not when you have 3 siblings outside the door not agreeing on what is the appropriate care. We're spending too much, and we're not, in many instances, doing the right thing for those patients.
This is one of the hardest things that you'll have to do as clinicians, which is to be able to counsel your patients and your families about what their options are. But it's important that you're able to do that in a sensitive way and in an empathic way. And I think some of the challenges that we see is that not everybody's good at it. It takes probably a gift to be able to do it. But it's really something that I think you probably need to focus on, and if it's something that you don't think you're comfortable with, find in organizations like Jefferson, find a mentor. So there are other people here that are good at it, but it's something that inevitably you'll be confronted with, depending on the type of discipline that you're practicing in. And speaking from personal experience, when my mother was chronically ill, she had congestive heart failure and COPD and was back and forth from the nursing home to the hospital, and that went on for about 6 months. Ultimately, thank God, she had the presence of mind to say, no mas, I'm done. And she made the decision. She was lucid enough to make the decision. And then the clinicians at that particular institution wrote the orders for hospice. And she went out on her own terms. But it's not always like that.
Question from the audience?
So this goes back to a question 3 or 4 questions ago about what happened in the 1970s and 1980s. You mentioned diagnosis-related groups as being part of the cause. But then, Dr. Connors, you mentioned that technology was a large reason why costs are vastly different from a lot of the European countries and us. But currently, the method that we're using to kind of solve this issue seems to be, at least the publicly perceived solution, is that we're going to close to a single payer system or something like that. But that only seems to address like the insurance overhead or maybe future incentives. And if technology is truly the reason why costs are vastly different between us and other countries, why aren't we just pursuing something where you cap technology? And how is that not affecting people in Switzerland and the Netherlands?
Well, if you go back to one of the earlier slides, we're dialyzing, 3 times the number of patients in this country. So what we need to do is back up. Why do we have so much chronic kidney disease? I mean, that's really where the savings is. We're dialyzing because we can. But what we need, and we're transplanting kidneys because we can. What we need to do is get back on the prevention side. The European countries do a better job, in many instances, in their primary care arenas. Pharmacists treat patients. For a lot of the primary care, you're in Italy, you walk in, the pharmacist will treat you for some of your basic medical problems. But the DRG actually reduced the payment to the hospital, and I didn't mean to confuse you, but at the same time we had a spiraling cost of technology where the hospitals lost, and please correct me if I'm wrong, where the hospitals lost is the technology was being used, but we were paying kind of at a capitated rate based on the DRG. So every time a new test came into play, we were playing catch-up and trying to pay for the cost of the machine and the utilization, et cetera, but we never really kept pace with the real cost in terms of payment. But the overall costs, the private payers are paying, and it's really cost-shifting. The hospitals are making up with what they're losing in Medicare, Medicaid, and non-payer by getting paid more from the private side. If we go to a single-payer system, I think that compensation will diminish even more.
Back in the 70s and 80s, we had something called a certificate of need requirement, and the intent there was to put a cap on the capital equipment that the hospitals would acquire. You could only have an expenditure over a certain limit on new capital equipment unless you could justify that there was really a community need. As it turns out, it created a cottage industry for consultants and how to get around the certificate of need requirements, and it wasn't terribly effective. If we put a cap on capital equipment that hospitals can have, I'm just concerned about the outrage that, as Neil was saying, the congressmen and women are concerned about, do my constituents have appropriate access? Well, if the hospital can't get the latest and the greatest, they may talk to the local congressperson and say, we've got a problem here, we'd like to provide this care for our patients, but we can't because it's been capped. And I guess you could go to extremes, and the old death panel argument could be raised that people are dying because we don't have